Imagine, if you will, the most chaotic, deafening industrial environment you can conjure up. I want you to picture a factory floor that stretches out to the horizon. It's hot, it's loud, and the machinery is moving at a speed that makes your head spin. You've got raw materials, amino acids pouring in from the loading docks. You have massive robotic arms seizing these materials. You have conveyor belts whirring by at breakneck speed.
It's a relentless scene.
Yeah.
And in the biological world, this isn't just an image. This is the reality of the bacterial ribosome. This is the factory floor of life itself. It's reading the blueprints, the mRNA, and assembling the proteins that keep a bacterium alive, replicating and, infecting.
Exactly. And today, we aren't here to marvel at the engineering. We are here to shut it down.
We certainly are.
Welcome back to the Deep Dive. Today, we are tackling the protein synthesis inhibitors. And I really want to frame this correctly because in previous deep dives, we talked about beta-lactams, penicillins, cephalosporins. I always pictured those as explosives. You throw a grenade at the factory wall, the wall blows out, the cell bursts, it's violent.
That's a fair analogy. It's a really good one, actually. Beta-lactams are structural destroyers.
Yeah.
But the drugs we are discussing today, tetracyclines, macrolides, clindamycin, linezolid, they are much more subtle. These are the saboteurs.
But saboteurs, I like that.
They sneak inside, they padlock the delivery doors, they jam a wrench into the gears, they cut the power to the conveyor belt.
And that distinction matters, doesn't it? Because usually when you blow up a wall, the thing dies immediately. That's bactericidal. But if you just pause the assembly line...
The bacteria doesn't necessarily die right away. It just stops growing.
Right.
It creates a state of stasis. That's why most of these drugs are classified as bacteriostatic.
Right.
They freeze the factory in time, holding the line until your immune system can show up and finish the job.
That is a critical distinction we're going to have to parse out because I know there are exceptions where the saboteurs turn deadly. Now, for sources today, we have gone to the absolute titans of pharmacology. We have Kitsum, providing the essential clinical architecture, the what do I prescribe and why, and we have Goodman and Gilman, which is essentially the molecular mechanics manual.
Goodman and Gilman is fantastic for this topic because the mechanism is the medicine. You cannot understand why we use azithromycin for pneumonia, but doxycycline for Lyme disease, unless you understand exactly which gear they are jamming in the ribosome.
So here is our mission. We are going to build a conceptual map. We need to understand the machinery, the 30S and 50S subunits. We need to understand the weapons, the drugs, and we need to understand the enemy's countermeasures resistance.
And we have to talk about the collateral damage. Because, and this is the tension of the whole episode, humans have factories too. We have ribosomes. So how do we jam their gears without jamming ours?
Spoiler alert, sometimes we don't. And that's where things get scary. But let's start at the beginning. Let's walk onto the floor. Section 1. The machinery.
To understand the machinery, we have to start with some math that drives medical students crazy.
I suspect I know where you're going. The Svedberg units.
The Svedberg units. So we are targeting the bacterial ribosome, which is called the 70S ribosome. It is made of two parts. A small part, the 30S subunit, and a large part, the 50S subunit.
Okay, hold on. I'm just a simple podcaster, but even I know that 30 plus 50 equals 80, not 70.
In normal math, yes. But biology loves to be difficult. The S stands for Svedberg unit. It's not a measure of weight or simple addition. It's a measure of sedimentation rate in a centrifuge. It's about density and shape.
Yeah.
So when you spin these things down, the 30S and 50S lock together to create a shape that sediments at the 70S rate. It's nonlinear.
So in the weird world of microbiology, 30 plus 50 is 70. And for humans,
We possess 80S ribosomes in our cytoplasm. Ours are composed of a 40S and a 60S subunit.
which brings us to the why. Why can I swallow a pill that stops protein synthesis and not die instantly?
Because the lock is different. These drugs are molecular keys cut with incredible precision to fit the 70S bacterial lock. They bounce right off our 80S ribosomes. If our ribosomes were identical to bacteria, antibiotics simply wouldn't exist. They would just be poisons.
However, Katsung drops a little foreshadowing bomb in the introduction. We aren't entirely ADS, are we?
We are not. This is one of the coolest evidences for evolution. Inside our cells, we have mitochondria, our power plants. It is widely believed that mitochondria were once ancient bacteria that got swallowed up by a larger cell a billion years ago. And the proof is in the pudding. Mitochondria have their own DNA, and they have their own ribosomes.
And those ribosomes look like?
They look suspiciously like bacterial 70S ribosomes.
So when we flood the body with a drug designed to sabotage a 70S bacterial factory, our mitochondria might start feeling the heat.
Exactly. We aren't shutting down the cell's main production, but we might be accidentally sabotaging our own power plants. This explains why when we get to drugs like linezolid or chloramphenicol, the toxicity profile involves things like bone marrow failure or lactic acidosis. Those are signs of mitochondrial distress.
That is such a key insight. It moves the list of side effects from random things to memorize to logical consequences of evolutionary biology.
Precisely. Now, let's look at the assembly line itself. Goodman and Gilman breaks this down into 3 stations. If you can visualize these 3 spots, you understand the whole drug class. You have the A site, the P site, and the E site.
I always visualize this as a ticker tape machine or maybe a 3D printer. The blueprint, the mRNA, is feeding through.
That works perfectly. Let's focus on the A and the P for now. The A site is the acceptor site. This is the loading dock. A delivery truck, which is a molecule called aminoacyl tRNA, backs up to the A site. It's carrying the raw material, the next amino acid for the protein chain.
Okay, so the truck is at the dock. The material is ready to be offloaded.
Then you have the P site. P stands for peptidome. This is where the work happens. The growing protein chain is hanging out here. The factory takes the new amino acid from the A site, bonds it to the chain in the P site, and the chain gets longer.
And then the line has to move.
Right. Step 3 is translocation. The ribosome ratchets forward along the mRNA blueprint. The empty truck gets kicked out the E site. That's the exit site. The A site becomes open again, and the process repeats.
And this happens fast.
Incredibly fast. Hundreds of times a second.
So we have the loading dock, A site, the assembly station, P site, and the conveyor belt movement, translocation. That's our whole world.
And every drug we talk about today acts as a saboteur at one of those specific points.
All right. Let's start the sabotage. Section 2, the 30S disruptors. We're looking at the tetracyclines. The name implies the structure, right? 4 rings.
4 fused hydrocarbon rings. It's a very distinct chemical signature. And this is a family of drugs that really shows you the generational evolution of pharmacology. You have the grandfather, tetracycline. We barely use them anymore. Then you have the parents, doxycycline and minocycline. These are the workhorses. And now we have the high-tech grandchildren, tigacycline, eravacycline, omadacycline.
Let's talk about how they attack. Where do they hit the factory?
They go straight for the loading dock, the A site. Tetracyclines bind reversibly to the 30S subunit, and they position themselves right in the doorway.
So the delivery truck, the tRNA, arrives with the amino acid. It tries to dock.
And it physically can't. The tetracycline molecule is sitting there, blocking the interaction. If you can't load the raw material, you can't build the protein. The factory doesn't explode, but production hits 0.
And because it's reversible, if the drug level drops, the saboteur leaves and the factory starts up again, hence bacteriostatic.
Exactly. You are relying on the immune system to come in and sweep up the stalled bacteria.
Now, getting into the factory isn't easy. Goodman and Gilman makes a point that these drugs don't just drift in. It's actually kind of ironic.
It is. In gram-negative bacteria, the drugs diffuse through porins, which are like little channels in the outer membrane. But then they are actually actively transported into the cytoplasm. The bacteria spends its own energy to pump the poison inside, thinking it might be a nutrient.
Talk about a Trojan horse. But the bacteria aren't stupid. They eventually realize, hey, every time I pump this thing in, my production line stops. So they adapt. And this brings us to resistance.
The #1 way bacteria defeat tetracyclines is by installing a sump pump. We call it an efflux pump.
I love this image. The drug leaks in or gets pumped in, and the bacteria just installs a high-powered drain pipe that blasts it right back out.
It's extremely effective. If the concentration of the drug inside the cell stays low, the A site isn't blocked. The factory keeps running. This is plasmid encoded, meaning bacteria can share the blueprints for this pump with each other. Hey, take this PDF. It shows you how to build a pump for doxycycline.
It's like a software update they pass around. Now, there is another resistance mechanism that sounds even more sophisticated: ribosomal protection.
This is fascinating. The bacteria synthesizes a specific protein. TET-M is a classic example. This protein is like a bouncer. It walks up to the ribosome, sees the tetracycline molecule blocking the A site, and physically shoulders it out of the way.
No way.
It uses GTP hydrolysis to change the shape of the ribosome, just enough to make the drug fall off, but still allows the tRNA to dock.
That is incredibly elegant and terrifying.
It is, and that's why we had to invent the grandchildren. Tigecycline.
Tigecycline is a glycyl cycline. How does it beat the pump and the bouncer?
It's all about bulk. Chemists took the minocycline structure and added a massive glycosamidose side chain. Think of it as adding a giant backpack to the saboteur.
Okay, so now the saboteur is wearing a huge frame pack.
2 things happen. 1, the molecule is now too fat to fit in the efflux pump. The bacteria tries to pump it out, but it gets stuck. 2, That bulky group creates new contact points on the ribosome. It grips tighter. So even if the protection protein tries to shoulder it, tetracycline holds its ground.
So it's a sticky, oversized padlock that you can't get rid of.
That's tetracycline. It silences the factory when the others have failed.
Let's move to the clinical side. Kitsung outlines the spectrum here, and doxycycline really seems to be the MVP.
Doxycycline is the outdoorsy antibiotic. That's how I categorize it. If you acquire the disease from a bug bite or an animal, doxy is probably the answer.
Yikes.
Lyme disease, Borrelia. Rocky Mountain spotted fever, rickettsia. Ehrlichiosis, anaplasmosis. Kitsung is very emphatic here. If you suspect Rocky Mountain spotted fever, you do not wait for the lab test. You give doxycycline. It is the difference between life and death.
Even in kids. Because we need to talk about the teeth.
This is the classic board exam contraindication. Tetracyclines are chelators. They love calcium. They bind to it chemically.
So if I take my doxy with a glass of milk?
You've ruined the dose. The drug binds the calcium in the milk, or the magnesium in an antacid, or the iron in your multivitamin. It forms a non-absorbable rock and passes right through you. You absorb nothing.
But if the drug does get into the blood, it still seeks out calcium.
And where's the calcium in a child? The growing bones and teeth. The drug deposits there. It can permanently turn the teeth gray or brown and can actually deform the enamel.
So the rule is, no pregnant women, no kids under 8.
With the exception of Rocky Mountain spotted fever, the American Academy of Pediatrics actually updated this. They said, look, RMSF kills kids, doxycycline saves them. A short course for a life-threatening infection is worth the risk of tooth staining, which, by the way, is actually very low with modern doxy compared to the old tetracycline. But for acne or a mild pneumonia, absolutely not. Stick to the rule.
It's also got that sun issue.
Photosensitivity. The drug deposits in the skin and reacts with UV light. I had a patient once who went to the beach on doxycycline and came back looking like a lobster. It happens fast. You have to counsel patients to wear sunscreen and a hat.
One last specific side effect, minocycline. It's often used for acne, but it has a quirk.
Vestibular toxicity. It penetrates the CNS and the inner ear really well. It can cause vertigo, dizziness, loss of balance. If a teenager on acne meds starts complaining that the room is spinning, check their med list for minocycline.
All right, let's leave the 30S loading dock and move down the line. Section 3, the 50S blockers. We are entering the realm of the macrolides.
The macrolides, erythromycin, clarithromycin, azithromycin, the Z-Pack.
Structurally, these are beasts. Macro is in the name. Giant lactone rings.
They're large molecules, and because they're large, they target the large subunit, the 50S.
Where do they jam the gear?
They block the exit. Specifically, they bind near the peptidyltransferase center and block the exit tunnel.
Help me visualize the exit tunnel.
Okay, remember the P site. The protein chain is growing. As it gets longer, it has to be extruded out of the ribosome, kind of like a noodle coming out of a pasta maker.
Got it.
Macrolides stand at the opening of that pasta maker and plug it. The ribosome adds 1 or 2 amino acids, but then the chain hits the blockage. It can't go anywhere. The process stalls. Eventually, the short, useless little peptide falls off, and the ribosome gives up.
So tetracyclines block the input, macrolides block the output.
Perfectly stated. It's a great way to think about it.
Let's talk about resistance here, because Kitsung describes something called the MLSB phenotype. This sounds like a secret code.
It's a very important code. It stands for macrolide, lincosamide, and streptogram B. These are 3 totally different drug classes. Chemically, they look nothing alike.
But they all bind to the exact same spot on the 50S ribosome.
Correct. They all compete for the same chair. So if a bacteria wants to resist them, it uses a strategy called methylation. It uses an enzyme, an methylase, to add a methyl group to the ribosomal RNA right at that binding site.
It changes the shape of the chair.
Just enough so the drugs can't sit down. And because they all try to sit in the same spot, this one modification confers resistance to all 3 classes simultaneously.
So you prescribe azithromycin for a skin infection, it fails. You switch to clindamycin.
And it fails too. That's the danger of the MLSB resistance. You might see this in the lab with something called a D-test, where they check for this inducible resistance.
Let's dive into the clinical personalities of these 3 sisters. Erythromycin is the oldest.
And the least used.
Yep.
Erythromycin has a unique side effect. It is a motilin agonist. Motilin is the hormone that makes your gut churn. Erythromycin essentially acts as a high-powered laxative.
I've heard surgeons sometimes use it just for that.
Yes. If a patient has gastroparesis, a paralyzed stomach, we might give erythromycin not to kill bugs, but just to wake up the stomach. But as an antibiotic, the cramping and GI upset are so bad, Compliance is terrible.
So we upgraded to azithromycin, the Z-Pack.
Yeah.
Why is this drug so popular?
Pharmacokinetics. Azithromycin is the king of half-life. It stays in the body for an eternity, around 68 hours is the half-life. But it's more than that. It has massive tissue sequestration.
What does that mean?
It means the drug doesn't just float in the blood. It gets taken up by tissues. Specifically, it gets taken up by fibroblasts, and get this, macrophages and neutrophils,
The immune cells.
the immune cells that are hunting the infection. So the white blood cell picks up the drug, travels to the site of infection, and literally delivers the antibiotic right to the bacteria. It's like the police car is also the bomb delivery system.
That is incredible. So that explains why you take it for 3 days or 5 days, but it works for 10.
Exactly. It lingers. Spectrum-wise, think respiratory. Community-acquired pneumonia. Strep pneumo, H-flu, Moraxella. It's also great for atypical pneumonias like mycoplasma or Legionella. And of course, chlamydia. A single 1-gram dose cures chlamydia. That's a public health miracle.
However, we have to talk about the heart. This is the scary part of the macrolide profile.
QT prolongation. Macrolides block the potassium rectifier channels, the IKR channels, in the heart muscle.
Let's break that down. The QT interval on an EKG is the time it takes for the heart's ventricles to reset after a VATE.
Right. Repolarization. If you block the potassium channels, that reset takes longer. The interval gets prolonged. If it takes too long and another beat tries to fire,
Kate, pause.
Coursod's to point. A fatal arrhythmia. Now, in a healthy person, the risk is tiny. But if you have a patient on other drugs that prolong QT like antipsychotics or some antidepressants or antiarrhythmics, or if they have low potassium or magnesium, you can stop their heart.
So check the EKG history and the med list. Now, there is one major difference between azithromycin and clarithromycin regarding the liver.
This is a crucial safety distinction. Erythromycin and clarithromycin are potent CYP450 inhibitors, specifically CYP3A4. They shut down the liver's metabolism of other drugs. If your patient is on warfarin, a blood thinner, and you give them clarithromycin, their warfarin levels will skyrocket. They could bleed out. Same for certain statins, which can lead to rhabdomyolysis.
And azithromycin.
Azithromycin is chemically different. It has a 15-membered ring instead of 14. It does not inhibit those enzymes. It interacts much less. So if I have a complex patient on 5 different heart meds, I'm reaching for the azithro, not the clarithro.
High-yield pearl, right there. Okay, section 4. The lincosamides. This is a class of 1, basically. Clindamycin.
Clindamycin, the anaerobic assassin.
We established it binds the same 50S site as macrolides. So why do we need it? What's its special niche?
Because it kills anaerobes bacteria that live without oxygen. But specifically, we say it treats anaerobes above the diaphragm.
Why that distinction?
Below the diaphragm, in the gut, the anaerobes, like Bacteroids, fragiles, are often resistant to clindamycin now. But above the diaphragm, mouth bugs, aspiration pneumonia, lung abscesses, Embionus clinda is still king.
I always think of clindamycin for dental infections, too.
Huge for dental. And for skin, it penetrates abscesses very well. It's also active against community-acquired MRSA. But there's a superpower clindamycin has that goes back to that sabotage metaphor, the eagle effect.
This is one of my favorite concepts in infectious disease. Explain it.
Imagine a patient has necrotizing fasciitis, flesh-eating bacteria, usually group A strep. These bacteria are growing wildly, but they're also reaching a high density, the stationary phase.
And beta-lactams like penicillin only work on growing cell walls.
Right. If the wall isn't being built, penicillin bounces off. Plus, the main damage in necrotizing fasciitis isn't just the bug, it's the toxin. The bacteria are spewing out exotoxins, superantigens that dissolve tissue and cause shock.
So you throw clindamycin in.
Clindamycin shuts down the protein factory instantly. It stops the production of the toxin even if it doesn't kill the bug immediately. It turns off the chemical warfare.
So in the ICU for flesh-eating disease, you'll see them hang penicillin to kill the bug eventually, and clindamycin to stop the toxin now.
Exactly. It's a critical combination. But clindamycin has a dark side, a notorious one.
The black box, C. diff.
Clostridioides difficile. Used to be Clostridium.
Why is clindamycin the poster child for C. diff?
Because it is so effective at wiping out the gut microbiome. It clears out the good police bacteria in the gut. That leaves an opening for C. diff, which is naturally resistant to clindamycin, to take over, multiply, and release its own toxins that cause severe colitis.
So great for lung abscesses, great for bone penetration and osteomyelitis, but watch the gut.
Every antibiotic can cause C. diff, but clindamycin is the highest risk offender.
All right, section 5. We are bringing out the heavy artillery, the last resort specialists. These are for when the factory is reinforced and standard sabotage has failed. Let's talk about the streptogramins.
Quinupristin and dalfopristin.
Sinersid.
This is a cool example of teamwork. Individually, these two drugs are bacteriostatic. They bind the 50S subunit. But together, they're bactericidal.
Sergi.
Molecular teamwork. Dalfopristin goes in first. It binds the ribosome and actually twists it, a conformational change. This twisting opens up the binding site for quinupristin to lock in much tighter than it could on its own. It's like one guy prying the door open so the other guy can throw the grenade in.
What do we use this for?
Not much anymore. It was designed for VRE, vancomycin-resistant Enterococcus faecium, but it has a huge hole in its coverage. It does not kill Enterococcus faecalis.
Faecium, yes. Faecalis, no. That's a trap waiting to happen.
It's a huge trap. And the side effects are miserable. It causes severe arthralgias and myalgias. Patients feel like they've been hit by a truck. And it destroys veins. You cannot give this through a regular IV in the arm. You need a central line, or it will cause thrombophlebitis. And it's a huge CYP3A4 inhibitor.
So it's toxic, hard to give, and has a hole in the spectrum. No wonder it's a last resort. Let's talk about a much more successful heavy hitter, linezolid.
The oxazolidinones. Linezolid is a game changer. Tetazolid is its newer cousin.
Where does it hit?
It targets the 50S subunit, specifically the 23S rRNA.
Oh.
But the mechanism is unique. It doesn't jam the gears while they are running. It stops the factory from opening. It prevents the formation of the initiation complex.
So the 30S and 50S never even join up with the mRNA to get started?
Never. The line never starts.
And clinically, this is the big gun for gram-positives.
MRSA, VRE, both pipes, faecium and faecalis. It's amazing for pneumonia because it penetrates lung fluid incredibly well. But the real magic of linezolid is its bioavailability.
It's 100%.
100%. The oral pill gives you the exact same blood levels as the IV drip. That is a unicorn in pharmacology. Usually you lose a lot in the gut.
This changes discharge planning. You can send a patient home with a pill for a superbug that usually requires weeks of IV therapy in the hospital.
Exactly.
Yeah.
But we have to circle back to the mitochondria. Linezolid is the drug where that evolutionary theory becomes a clinical reality.
Because it inhibits protein synthesis so well, it starts inhibiting our mitochondrial ribosomes.
If you keep a patient on linezolid for more than 14 days, you start to see the factory workers, the blood cells, disappearing. Thrombocytopenia, low platelets, is the first sign. The bone marrow is being suppressed.
And long-term.
Neuropathies. Optic neuropathy patients can go blind. Peripheral neuropathy, numbness, and pain in the feet. Lactic acidosis. These are classic signs that your mitochondria are failing to produce energy.
So it's a time-limited weapon. Use it, kill the bug, get out.
There is one more interaction with linezolid that is totally weird. It's an antibiotic, but chemically it's also a weak, reversible, non-selective MAO inhibitor.
Monoamine oxidase inhibitor. That's an old-school antidepressant mechanism.
It blocks the enzyme that breaks down serotonin and norepinephrine. So if your patient is on an SSRI like Prozac or Zoloft, and you give them linezolid,
Serotonin levels spike.
serotonin syndrome, fever, agitation, tremors, hyperreflexia, they can be fatal. Same thing with tyramine-rich foods like aged cheese or red wine.
So you are treating their pneumonia, but suddenly they are rigid and seizing because of their antidepressant. That is a deep dive connection right there.
Always check the psych meds and diet before starting linezolid.
Section 6, the do not touch button. Chloramphenicol.
Chloramphenicol, the drug we love to teach but are terrified to use.
It hits the 50S peptidyltransferase. It's actually a brilliant drug, broad spectrum, goes everywhere, even the brain.
It's an incredible drug. In the developing world, it's still used because it's cheap and effective. But in the West, we fear two things. First, Gray Beatty syndrome.
The name alone is a horror movie.
It's literal. Neonates, especially preemies, lack a liver enzyme called UDP-glucuronidyltransferase. They cannot metabolize the drug. It builds up to toxic levels. They vomit, go limp, get hypothermia, and turn an ashen gray color due to cardiovascular collapse.
And in adults.
Plastic anemia. This is the scary one because it is idiosyncratic. It's not dose-dependent. You take one drop of eye drops containing chloramphenicol, and if you were genetically unlucky, your bone marrow just turns to fat. It stops making blood, irreversibly.
So the risk is 1 in 30,000 or so, but the consequence is death.
Which is why we almost never use it, unless it is bacterial meningitis in a patient who is anaphylactic to penicillin and cephalosporins. Then maybe. Or certain rickettsial diseases. But it's the definition of Hail Mary.
Finally, just a nod to Section 7, the miscellaneous players, lefamulin and mupirocin.
Lefamulin is exciting because it's a pleuromutilin. It's a brand new class that hits the 50S subunit at the peptidyl transferase center. It was developed to treat community-acquired pneumonia, and because it's structurally unique, the usual resistance mechanisms don't affect it yet.
And mupirocin.
That's your topical powerhouse. It targets isoleucyl tRNA synthetase, so it stops the loading of the delivery trucks before they even get to the factory. Its claim to fame is decolonizing the nose. If you have MRSA hiding in your nostrils before surgery, mupirocin is the eviction notice.
We've covered a lot of ground. We've padlocked the 30S loading dock with tetracyclines. We've gummed up the 50S exit tunnel with macrolides. We've turned off the toxin with clindamycin and shut down the power grid with lanazolid.
And we've seen how the bacteria fight back with pumps and methylation and bouncers.
Let's try to synthesize this into a framework for the listener. If I'm a student or a clinician, how do I file these away mentally?
I like to give them personalities. It helps anchor them.
Go for it.
Tetracyclines, doxy, the outdoorsman, ticks, nature, weird bugs, STIs like chlamydia, but watch the sun in the teeth and don't take it with milk. Macrolides, azithro, the respiratory specialist, pneumonia, sinus, and STIs. But watch the heart rhythm and drug interactions, especially with clarithromycin, clindamycin, the anaerobic assassin, abscesses and toxins above the diaphragm. But fear the C. diff. Linazolid, the oral big gun. Use it for MRS AVR when you want to send them home, but don't use it too long, or the mitochondria rebel, and watch for serotonin syndrome.
And chloramphenicol.
The historical ghost. Just don't, unless you have absolutely no other choice and you've had a long conversation with your infectious disease consultant.
I want to end with a philosophical question on resistance. We talked about the arms race. We build a better saboteur, tigecycline. They build a better pump. We build a new 50S binder, lefamulin. They methylate the site.
It is an endless cycle. The bacterial ribosome has been evolving for billions of years. It is incredibly plastic. Every time we apply pressure, every time we write a prescription, we are selecting for the mutant that knows how to survive.
So are we winning?
We are holding the line. But notice how we have to keep inventing grandchildren drugs. We went from tetra to doxy to tigecycline to omadacycline. We have to keep adding bulk, changing shapes, just to keep up. It suggests that we aren't winning. We are just staying one step ahead of losing.
That is a sobering thought to end on.
It is. It's why antibiotic stewardship matters. Don't use the big gun when a slingshot will do. Don't treat a virus with a bacterial saboteur. You're just training the enemy for no reason.
Listeners, your mission is clear. You have the map. Now go read the territory. Open Katsung, chapter 44 and 50. Open Goodman and Gilman, chapter 59. Look at the chemical structures, see the four-ring, see the lactone, make the knowledge your own.
Because when you are at the bedside at 2 a.m., you don't want to be guessing. You want to know exactly which gear you are jamming.
Thanks for diving deep with us. We'll see you on the next shift.
Stay curious.